Good afternoon, everyone. Can everybody hear me?
Yes, I can.
Perfect. Oh, good. Perfect. Okay, great. I will, if we can see the screen, let me get you introduced, Dr. Killen. Let's start with, we're Apex Biologix, so we're a complete resource for regenerative medicine. We're fortunate enough to be partnering with Dr. Killen. I'm Troy Openshaw. I help manage the sales team, and then also on the call is Kaho, and he's the director of marketing and operations. So with us today, we have Amy Killen, Dr. Killen. She's an anti-aging and regenerative physician specializing in sexual optimization, aesthetics, and integrative medicine. So she's board certified in emergency medicine with 10 years of ER experience. Dr. Killen, during that time, she's seen the impact and unchecked chronic disease and disability from the front lines before transitioning to anti-aging and regenerative medicine. Dr. Killen is fellowship trained in anti-aging and regenerative, metabolic, and nutritional medicine throughout the American Academy of Anti-Aging Medicine. Some of the other affiliations that she has is with the American Board of Emergency Medicine, Academy of Regenerative Practices, and International Society of Sexual Medicine. She's an international speaker, clinical practice owner, medical director of a national regenerative medicine physician training course, author, and frequent podcast and media guest. She's become an outspoken advocate for empowering patients to look and feel their best by emerging lifestyle modification, hormone optimization, personalized medicine, and regenerative therapy. So we're obviously very, very fortunate to have her for a few minutes today. And with that, I'm going to hand the time over to you, Dr. Killen.
Thank you. All right. So first of all, thank you for the very nice introduction. I am going to spend hopefully about 30 minutes, maybe 40 minutes if I go a little long, talking about male sexual optimization. And I want to give you a little idea about my background. I won't go too much into it, but I was an ER doctor for about 10 years. And towards the end of that, started practicing and learning about anti-aging medicine, integrative medicine, metabolic medicine, whatever you want to call it, and regenerative medicine. Eventually moved out of state from Austin to Portland, opened my own practice in doing mostly hormones, but was starting to do some work with PRP at that time as well. And then later moved to Salt Lake City, which is where I live now, and became really interested in stem cells and started doing some work with stem cells as well as PRP and other biologics. And then I also have an integrative medicine practice here in Salt Lake. I've been teaching for Apex Biologics, the aesthetics and sexual courses for a couple of years now. I'm the course director. I do most of the teaching for that course. I also have some other advisory boards that I do. My expertise is, I really enjoy sexual health. I'm not a urologist, which I think is important to note. I'm also not a, OBGYN. I oftentimes refer patients to those other specialties. And I think it's important to kind of know what my limitations are in those regards. So we're going to kind of just get started. We're going to talk about sort of traditional approaches to male sexual dysfunction first, and then dive into some of the newer data on regenerative therapies, which are things that I'm really excited about. And that includes PRP, stem cells, exosomes, shockwave therapy, some of those kinds of things. Okay, so with the erectile dysfunction, male sexual dysfunction, we know there are a couple of different types. There's the ED, there's just the libido problems and ejaculation problems. And we're going to focus mostly on ED because that's what people generally are coming in for, at least in my office. Of course, we all know that ED is a risk factor for other chronic medical problems. 40% of men in their 40s will start to have some level of erectile dysfunction, and that number goes up by about 10% per decade. So we'll see a graph here in a second that shows that, but it starts usually at about the early 40s for men are starting to see problems. Major risk factors are anything that can cause inflammation. So of course, high blood pressure, diabetes, heart disease, obesity. Obesity is a really big one, actually. Obesity increases your risk of having ED by about 40%. Hypertension is also a really big one because it causes that endothelial dysfunction. And of course, any kind of neurologic disease where you're having difficulties with the nerves getting down into the pelvis is a problem. Hypogonadism hypogonadism, which is more of a problem now than it used to be. And low testosterone is a big problem and something that you want to look at as well. Smoking. I mean, I always tell my patients that I feel like that the cigarette boxes should have a picture of a flaccid penis on the front of them. Like, I feel like people should just know what they're getting themselves into when they pick up that box of cigarettes, because it's such a bad risk factor for all kinds of things, but also for ED. And then medications, of course, there are lots of different medications that are associated with sexual problems. SSRIs are obviously known, all kinds of diuretics and beta blockers and antifungals. And finasteride, it gets a lot of press for it. It's actually not that big of a problem for most people. Only about 2 to 3% of men who take finasteride, especially at the lower doses for hair loss, will have sexual problems. But it is something that can happen because of that decreased production of DHT when taking finasteride. This is your sexual ED curve. So you can see that starting at about age 35 or 40, the percent of men who have ED goes up significantly, and it just keeps going up, up, up. We all know, I think by now, that ED is kind of like the canary in the coal mine. It's an early warning sign for other diseases, oftentimes, not always, but it's something that's definitely worth thinking about if you have someone who's coming in with ED. The blood vessels that supply the penis are smaller than those that supply the heart or the brain. So, some atherosclerosis is going to clog up those penis blood vessels faster than it will the heart of the brain. So it makes sense that we would see signs of erectile dysfunction before the heart attack, before the stroke. So it's important to make sure that general health is being looked at with patients for this reason. All right. So, I worked for many years as an ER doctor, and I knew generally kind of how erections worked, but I found it fascinating in the last 6 years or so when I started doing more sexual health, because I didn't really understand all the mechanisms. The most common type of ED, of course, is vasculogenic. So vasculogenic ED is a lack of blood flow, right? The blood is either it's not getting there or it's not staying there. Then, of course, you have neurogenic ED, so that could be from actual neurologic diseases or things that cause nerve injuries, spinal cord injuries, diabetes, things like that. Hormonal, which is often low testosterone, but can be other things like high estrogen or even low estrogen sometimes, or other hormonal problems can sometimes cause it. And then psychological, which we'll talk about here in a minute briefly. For the vasculogenic ED, there's two primary types. There's the arterial insufficiency, which is a atherosclerotic disease, so the blood is not getting to the penis, and that's the kind that people kind of always think about, I think, with ED. But what's actually more common is what's called CVOD, or cavernosal veno-occlusive disease, or venous leak, people call it, which is trouble maintaining an erection. And I feel like this is kind of a misnomer, this venous leak, because the veins are not the problem. The veins are not leaking. They're functioning just fine. The problem is the smooth muscle cells. So you can see in this diagram that kind of tan part in the middle of the corpora, that's your corpus cavernosum smooth muscle cells. And those cells are supposed to be elastic. It's supposed to, expand. And it's a really important part of their function. And so when you're young and healthy, like in number A, you get an erection that's caused by nitric oxide. Nitric oxide is going to open up the blood vessels, the arteries, to get the blood there. Nitric oxide is also going to relax those smooth muscle cells so the blood can come in. Those cells can open up, and you get this expansion. And that expansion puts pressure then on those venules, those little veins around the edges, so that the blood stays there for a little bit of time. And that's normal. And then what happens later, after you have as little as about 15% of those smooth muscle cells die, so you have apoptosis of smooth muscle cells, which again is oftentimes related to inflammation and age. When that happens, those smooth muscle cells can't expand completely. And then you don't have the clamping off of the vein, so the blood comes in, but then it just comes right back out again. So that's a venous leak, but it's actually a smooth muscle cell problem, not a venous problem. All right, treatment together is better. So I always, you want to look at all the different things that you could do for a patient and start with psychological. the things I ask about, certainly main things: depression, self-esteem issues, relationship issues. Porn addiction is a big one, especially for younger men. If I have 25 or 30-year-old guy who comes in with erectile dysfunction, I always ask about porn use and porn addiction, because we're seeing more and more of that. It's actually, causing the dopamine changes in the brain, like any addiction, where they have to have higher and higher stimulation to get their desired effect. And this can cause ED in their actual relationships with real people. So that's important. Lifestyle, we kind of talked about: low inflammatory lifestyle, low glycemic diet, anything that's going to prevent inflammation, cardiac disease, atherosclerosis, et cetera, is important. Testosterone, I'll talk about here in a second, nitric oxide as well. The medications, I still use a fair amount of medications, even though my practice is integrative. I'm trying to integrate both sort of allopathic medicine, regenerative medicine, and other types of nutraceuticals and things into the plan. PDE5Is, of course, are the mainstay of treatment, and I use them quite a bit in these patients. There is some evidence in certain disease processes, like post-prostatectomy patients and such, where the PDE5Is, because they're keeping nitric oxide around longer and making that more available, that actually has some protective effects and seems to decrease the rate of apoptosis of those smooth muscle cells in the penis. So I use a lot of PDE5Is in conjunction with other therapies, especially kind of while we're treating them and trying to get the blood flow in and trying to get the repair to happen. Of course, the intraurethral, the prostadils, the injections, all of those are also possible. I leave a lot of that to the urologist to do, but that's another option. And then the regenerative medicine injections, we'll talk about. Vacuum erection devices or penis pumps are something else that I have a lot of patients use. And certainly if I'm doing injections on them, or if I'm doing the shockwave therapy for them, I will give them or sell them a penis pump, because I think it's really important to get the blood flowing and to get the oxygenation. If we're going to repair that tissue, we have to have blood in it. So pumping, it's a great way to improve function in these patients as well. And then the low intensity shockwave therapy, I use the protocol through Gainswave, which is just sort of a protocol, but shockwave therapy we'll talk about at the very end. All right. So this is my Together We Stand approach to treating ED. So basically using all different treatments in combination. The right combination is going to be more effective than just picking out one and using that one. This is a place in Turkey called Love Valley, which I've never visited, but I think it looks like a lot of fun. All right, so testosterone, I've been doing testosterone replacement and other hormone therapy for a number of years now. And the key to this slide here, what I want you to kind of take home, is that low testosterone affects erectile function in a number of ways. So we know that low testosterone causes low libido, and that's something that, all of us, I think, recognize. Low sex drive, you have, low testosterone, you're not interested in sex, and that's important. But low testosterone chronically over time also has been shown to affect the health of the smooth muscle cells in the penis. So men who have chronically low testosterone, those smooth muscle cells get replaced by collagen and fibrous kind of scar tissue, or by fat, and they don't work as well. So low testosterone can directly affect erectile function in that way, and then it indirectly affects erectile dysfunction as well, because low testosterone is associated with increased risk of metabolic syndrome and type 2 diabetes, of course, to cardiovascular disease. It's also associated with obesity. And so we know, of course, all of those things also cause ED from different mechanisms. So testosterone actually is really important, and every patient that I am treating for ED, I get their testosterone levels checked. I check free, I check total, I check some of the other hormones associated with it to make sure that we are optimizing those things. All right, nitric oxide is something I think is also overlooked in this patient population quite a bit. We know that medications like the PDE5Is are working to basically keep nitric oxide around longer. Of course, they work on cyclic GMP and preventing breakdown of cyclic GMP, but that cyclic GMP gets formed because of nitric oxide. So the cavernosal nerve releases nitric oxide. Nitric oxide then goes and communicates with, again, the arteries to bring the blood in, and it also talks to those smooth muscle cells to open up and relax and let the blood come in. As we get older, nitric oxide levels go down significantly, especially in people who have a poor diet and lifestyle. So that you look at those lines here, and the red line at the bottom are patients with poor diet and inactivity. And you can see just this precipitous drop in nitric oxide production in those patients. So if you imagine that one of those patients comes in and they say, hey, my Viagra isn't working anymore. And you can look back and you can think, why would that be? Well, one reason might be that they don't have enough nitric oxide, because Viagra does require that you make or have your own nitric oxide to be able to keep it around longer. So that's a really important key point. And this is just another picture as the reason that we see a decrease in nitric oxide with age, one of the reasons at least, is that a lot of the nitric oxide is made by the endothelial cells in our blood vessels. So of course, as we get older, you develop atherosclerosis, and all of a sudden you can't make nitric oxide anymore because you've got inflammation there instead of the ability to do that. So we lose about 85% of our ability to make nitric oxide as we get older. And that is a big deal for the whole body, but it's also a big deal for the penis. This is a little chart that I like to talk to patients about when they come in, things that they can do to boost nitric oxide. There are quite a few things that they can do just in their lifestyle. So leafy green vegetables like spinach and kale, beets, pomegranate, even dark chocolate has a fair amount of nitrates in there that get converted to nitric oxide. Exercise is a key, obviously increases nitric oxide and is really important for these patients. Supplements, there are a number of supplements out there that increase nitric oxide. I really like Neo 40 by Dr. Nathan Bryan, because it has a lot of good research behind it for all different things, from from decreasing blood pressure to triglycerides to other types of performance, and then any other kinds of antioxidants in the food or taken as supplements might be helpful, because you could you're trying to decrease atherosclerosis. So anything that decreases atherosclerosis could potentially increase nitric oxide. Things that are bad for it, and this is something I see every day with patients, proton pump inhibitors are bad for nitric oxide. Proton pump inhibitors change the acidity of the stomach, which is where some of the bacteria are that do some of the conversions to make nitric oxide. So in these patients who are on chronic PPIs, they're not making as much nitric oxide as they want to. And this may be one of the reasons why we know now that chronic use of PPIs is associated with a significant increased risk of heart disease, of atherosclerosis and coronary artery disease. And I suspect that at least part of that has to do with lack of nitric oxide, which is so important for endothelial health. All right, so regenerative treatment options. We will run through some of these, and I've provided the links to the studies that I'm talking about here. I've not put every single study in here because that would be really long and boring, but I've put some of the ones that I think are interesting and important. So PRP, I think by now most people know what PRP is. PRP is when we take a person's blood and we spin it, and this is in a centrifuge, and then we are able to, you have the serum layer on top and you have the red blood cells on the bottom. And then right there where that arrow is pointing, kind of in the middle, right above the red blood cell layer, the lower part of the serum is where the platelets are. So that's where they're kind of concentrated and they're hanging out in the serum. And what we're able to do is we pull off that specific layer where all the platelets are. You're also going to get some white blood cells in there as well, and that's okay. But that's the PRP. We're trying for concentrations of PRP that are usually about 6 to 9 times the whole blood concentration for most of these PRP procedures. And I use some kits to do that. Some people use do-it-yourself methods, which I think it can work for some people, but I like the idea of knowing exactly what I'm doing as far as how many platelets I'm using. But that's the PRP. I have a couple of studies here that we'll talk about. If a study is in animals, you will not see it, but in human studies, I put a little icon of a little man at the bottom, so we can easily look and see. A lot of the PRP studies are in animals. In fact, I've only pulled out 2, but there are many studies in rats using PRP for erectile dysfunction. So they take these rats, this particular one, they took rats and they did a bilateral cavernous nerve crush injury. And so they crushed the little tiny cavernous nerves, which is sad, in these rats. And then with the treatment group, they put PRP right around the site of injury. Placebo group, they just injected normal saline. And then they waited 4 weeks. So 4 weeks later, they went back and they said, well, what happened? And they found that the PRP treated groups resulted in significant recovery of erectile function and preservation of the axons in those cavernous nerves. This particular study, this type of study has been done many times. This is another version of it, but again, 24 rats, they did cavernous. This was a transection instead of a crush, but they transected the cavernous nerve. And then in one group, they immediately sutured it. The second group, they sutured it, but they put some PRP in there first. And then the last one's a sham operation where they didn't actually cut the nerve at all. And at 3 months, what you can see is that the suture-only group, so it got the nerve cut, but nothing else was done. The intracavernosal pressure, which is ICP there, is 46, which is not very good. But the PRP group, where they got PRP after the nerve was crushed or was transected, the ICP is 94. So you've got, a doubling of your ICP, your pressure in the cavernous corpus cavernosum. And then the placebo group, which was the nerve wasn't cut at all, the pressure was 109. So you can see that, just at 3 months, the PRP group, got these rats almost back up to where they would be if they hadn't had the surgery in the first place. So again, number of studies like this. There are also some other rat studies that are diabetic rat models, where they'll use like streptomycin or other things like that, and they will cause a rat diabetes, and then they will use PRP. Almost always intracavernosal injections in these rat studies, although I'll show you one that's not, but it's usually intracavernosal single injections for the most part of PRP, and they'll see things like improved blood vessel formation, nerve regeneration, erectile function, etc. And this was the result of that one I just talked about. And basically they said, PRP can promote the regeneration of the injured cavernosal nerve and the recovery of erectile function. All right, this is a human study, and we know that because it has a picture of a little human there at the bottom. This was pretty recent, actually, 2018. So they took 60 men, and they divided them into two groups. Group A, they received just 4 milliliters of activated PRP. So that little a means activated. Usually when they activate it, they're usually adding like calcium chloride or calcium gluconate or something similar to open up the platelets so the growth factors get immediately released into the syringe, so that when you inject it into the penis, you already have active growth factors that are ready to kind of get down to business quickly versus having to wait for them to activate naturally. So that's what that little a means there. And most of the PRP procedures that I do in aesthetics and hair and sexual function do use an activated PRP. So anyway, these men had activated PRP, only 4 mLs, pretty small amount, injected once a week for 3 times. And then group B had the same number of PRP injections, but they also received 5 milligram tadalafil or Cialis for the first 28 days. And what they saw was that at 4 weeks and also up to 3 months, so between 4 weeks and 3 months, group B, which is the one that had the Cialis and the PRP, were starting to show improvements in their IIEF, which is a International Erectile Function scale, and then EHS, which is an erectile hardness scale. So even at as early as 4 weeks, we're starting to see improvements of that. But that was patients who had both tadalafil and PRP. At 6 months, both groups, so the group that just had PRP plus the group that had PRP plus the tadalafil, both of these groups showed improved endothelial function when measured by Endopat, and also improved resistance index in those cavernosal arteries. So their conclusion was that it seems that the PRP seems to be able to improve vascular endothelial function and erectile hardness to treat ED. Certainly, it looks like if you want to have a quicker result, using the tadalafil in combination with it might be helpful. What's one thing that's not necessarily stated on all these slides, but that you'll find when you start looking into this, is that PRP is extremely safe. Like, never are there are problems as far as, certainly you can get a bruise or something from the procedure, but beyond that, you're not going to get side effects. And this is seen over and over again in rat studies and human studies. No matter where you put it, it's very, very safe. Obviously, same things like bruising, infection risk, those are all possible because it's a procedure, but the actual PRP is very safe. And the same thing is actually true for stem cells. I'm going to talk about that in a minute, but in all these stem cell studies, the conclusion is this is safe. Whether it's effective for everyone, maybe not, but is it safe? Yes, it seems to be. Okay, this was kind of an interesting one, and I just found it, but it's great because I have patients all the time who come in asking me if PRP or pumping or shockwave therapy, if they do that, are they going to see an increase in the size of their penis? And I always tell them, like, you know, my focus is not on size, my focus is on function and making sure the function is improving. And I talk about the endothelial health and, you know, all the things. And they're just staring at me and they're like, yeah, but what about my size? And so this is the first one that I found that it actually looks at PRP in combination with vacuum pumping for penis enlargement. And it took 1,200 men who had small penises. Some of them had ED, some did not. Some had Peyronie's disease, which is a scarring disease of the penis. Some did not, but they all had a small penis. And they did injections of PRP into the corpora once a month for 5 months. And then they also had the patients use a vacuum pump at home daily for 20 minutes, which is kind of a long time. And I don't, these are pretty, these patients must have been very compliant because most of mine would not do that. But 5 months of pumping and then total of 5 PRP injections. And what they found at 6 months was that they were able to increase the mean penile length up to about 35 millimeters, which was, you know, 3.5 centimeters, which is not insignificant. You know, 3.5 centimeters is pretty good. And then the increase of penile girth was about 30 millimeters or 3 centimeters. So they did see increase in length and girth in most of these patients, and 70% were satisfied with their erections at that point. Again, no adverse side effects. And, you know, of course, the question is, well, how much of the pump, you know, was the pump important? Yes, I think it was. I think you have to do both. I was unable to find any studies that looked at just pumping to see, well, if we did that much pumping for 5 months, you know, what do we get from just the pumping? I did look into it, but I haven't found that yet. And then Peyronie's disease. If anyone who's starting to treat erectile dysfunction as a big part of their practice will see these patients who have Peyronie's disease. It's very common. It's the scarring disease of the penis where you get this fibrotic changes in the tunica albuginea, and we don't really know why. It may be autoimmune or it may be trauma, but basically the scarring can cause curvature, and it can cause pain, and it can cause erectile dysfunction. So this was a study that looked at using PRP in combination with hyaluronic acid in 13 men with Peyronie's disease. And they received intralesional injections of PRP and the hyaluronic acid 4 treatments over 2 months. And what they saw was that at 9 months, 77% had improvements, which is big, which is really big for Peyronie's disease, where there's not a lot of great treatments out there, and it's a chronic medical problem. And then the mean 30% decrease in curvature and about 53% decrease in plaque size. So again, these are all small studies, and I absolutely recognize that we need bigger ones, we need more of them, but there are some encouraging things that we're seeing. Okay, so briefly, you may have heard of the P-shot or the male PRP shot. It's kind of the generic name, but the P-shot or Priapus shot, which Dr. Reynolds developed several years ago, is using PRP injections into the corpora, as well as there's an injection as well at the corona. And this is kind of some of the things that men report. It's mostly anecdotally. There's not a ton of evidence, except for what I've just shown you in animals as far as what men have seen. But stronger erections, increased arousal and libido. You know, I've had men tell me that the skin on their penis is more youthful appearing, which is interesting. Improved sensation, you know, more pleasurable orgasms, and then again, potentially increase in length or girth of the penis. Here is the anatomy that we are looking at. And let's see, I learned how to use a little drawing tool just recently. Let's see how this works. So, you know, we're going to be going into the corpora, and what I'm injecting, I'm basically kind of going in here with one injection, and then I'm going in here with one injection, just into the corpora, and at a couple of different spots on each side generally. Although it is you could just do even 1 or 2 injections. You obviously don't want to inject over the blood vessels, and you don't want to inject over the urethra, but sort of this 10 and 2 approach to the injections with the PRP or whatever you're using is what I do. And then I also do a single injection over, again, at the corona, which is the base of the glands. All right. Let's see how to get out of that. Perfect. Okay. Oh, yes. This is one of my most scientific slides. So this is the patients before the P-shot, and this is the patients during the P-shot. This is the patients after the P-shot. super scientific, this part. So, make sure you get the sources on that. Anyway, all right, so moving on. So I'm going to talk a little bit about what's happening in the field of stem cells and other biologic in terms of ED, because I think that this is really cool. And there's actually a lot going on right now in this field. And even if this is not something that most of us are interested in doing or able to do, I think it's worth knowing about, especially for patients who really want to try, all different things and have severe disease. So the first one here is a rat study, and it's using adipose-derived stem cell exosomes. So exosomes, these first few slides are about exosomes. Exosomes are, if you remember from a long time ago from cellular biology, exosomes are these little pockets, these little like bubbles of information that stem cells release to communicate with other cells. So one of the ways stem cells talk to other stem cells or other cells in the environment are they release these little baby exosomes, which are very tiny. They're about 40 to 100 or so nanometers in size. They have proteins and growth factors and messenger RNA, cytokines, etc. inside, and they are able to, they drift in through the fluid and they can talk to other cells. So what's been shown, and these are some animal studies on that, is that because we know that most of the time when we're using stem cells for ED, the stem cells are not actually engrafting. So they don't work by essentially becoming part of that tissue. You inject them and then they send out signals to your own stem cells that are already there, your own other cells that are already there. And then they start that regenerative process, but your body's doing the regeneration. The stem cells are acting more like messengers. They're sending out these signaling molecules. So the using of exosomes is taking advantage of that signaling component of stem cell therapy. So this study was 24 rats, 3 groups. They used the first group, they used adipose. These were rats who had diabetes, type 2 diabetes model rats. So in one group, they injected adipose-derived stem cells, and these are going to be, of course, your mesenchymal stem cells, which are the ones we get from fat. Group 2 was exosomes that were taken from adipose-derived stem cells. So there's no actual DNA. You're not putting in the stem cell. You're just putting in these exosomes. And then group 3 was saline. And what they found was that both adipose-derived stem cells and exosomes acted in a similar way and caused similar results. So both of them, they saw increases in intracavernous pressure. Compared to saline. They saw increases in the ratio of smooth muscle versus like collagen or fibrous tissue in the corpus cavernosum in both of those. And then they also saw in both the regular stem cells as well as exosomes inhibited apoptosis of smooth muscle cells, which again, that's really important because once you started having too much apoptosis, that's when you start getting a venous leak. So basically, this one showed that both stem cells and exosomes cause similar effects in that model. And this is another one. It was a very similar study that was looking at a cavernous nerve injury model of rats. So again, nerves are injured, and they either injected mesenchymal stem cells, which is what MSCs are. In this case, they were from bone marrow, but they're very similar to the types gotten from fat, essentially the same cell, just gotten from different areas. So mesenchymal stem cells from bone marrow versus mesenchymal exosomes, so just the messenger bubbles, to see what was best, what worked well. And what they found was at 4 weeks that both the mesenchymal stem cells from bone marrow and the exosomes, they worked in very similar ways. They both increased smooth muscle content in the corpus cavernosum. They both increased neuronal nitric oxide synthase. So again, you can make more nitric oxide if you have that in NOS in effect. They both inhibited apoptosis, and they both improved erectile function as measured by the cavernosal pressure. So this is another one, same type of thing, but basically showed that when we take these exosomes in vitro, we see pro-angiogenic properties. And that's true really of any of these regenerative things. So whether it's PRP, stem cells, or exosomes, we see angiogenesis is one of the main things that we see. So improved blood vessels and better blood flow to the area, because that's important. You have to have the blood flow if you're going to be trying to heal these tissues, and all of those things are pro-angiogenic. With the exosomes, they also saw, again, increased improved erectile function, decreased fibrosis, and improved endothelial cell proliferation. This was an interesting one that it's been around for a few years, but I thought I just found it. But effects of IV injections, so not intracavernosal, but just in the IV, actually injected into the tails of these little rats in a rat model who had a radiation therapy induced erectile dysfunction. So they took these 30 rats, they had in the control, they didn't do anything to them. They just used saline and they were fine. The next group, they did radiation over the rat's prostate, and then they followed it up with some IV saline. And then the third one, they did radiation over the prostate, and they followed up with IV stem cells obtained from fat. And these stem cells were labeled with radio labeled as well, so they could look at them. So what they found was after 17 weeks that certainly the radiation, the rats who had radiation of the prostate were more likely just in general to have, decrease in erectile function and expression of the neuronal nitric oxide synthase as well. But what was interesting about it is that the group that got the IV stem cells right after their prostate was radiated, that group there on the second bullet had significantly restored erectile function, improved nitric oxide synthase expression, and they had more and better cavernous smooth muscle content than those irradiated rats. The other thing that is important to note in this study, which has been shown in other studies as well, is that even though whether you put the stem cells directly into the penis, into the corpus cavernosum, or you put them IV, where they end up is in this major pelvic ganglia. And so they're not necessarily staying where you put them in these cases, but they're still able to exert their signaling effects, their paracrine effects, from wherever they are, from that pelvic ganglia. So this is really cool and a cool option of potentially just doing IV therapy for these patients. All right, what about humans? And I'll try to wrap up here in the next 5 minutes or so, but there's so much good stuff. I can't stand it. So I have 4, I think, small kind of little trials with humans that are here in a row, and you can look at them more closely. This first one was diabetic men, and they use umbilical cord stem cells. And again, these are umbilical cord, usually they're mesenchymal stem cells. We're talking about ED. So it's not the hematopoietic. Hematopoietic are the ones that are used to make blood. You can get that from cord blood as well, but this is mesenchymal stem cells obtained from the umbilical cord. So they have diabetic men, and they injected these cells into the corpus cavernosum, and then they also had a placebo group where they just injected saline. What they found at 2 months was that 6 of 7 men who had the actual cord cell injections had return of morning erections. 2 of 7 could get erections strong enough for sex just on their own, and 5 of them needed to still use PDE5-Is, but with the PDE5-Is were able to have sex. And this is a population of men who weren't responding at all to PDE5-Is. They couldn't get erections with them before, and now they've become more responsive to them. Interestingly enough, in this study, and this is not really a surprise to me at this point, but these men also had improvements in blood sugar levels after getting these stem cell therapies. Because again, the stem cells are not staying in the penis. They go in there for a little bit, they hang out, they release some growth factors, and then they go into either the pelvic ganglia or the bone marrow or other parts of the body. And so that, it's possible they can exert some systemic effects as well. Again, none of these studies, they have serious adverse events. This is another one with men post-prostatectomy. They use bone marrow-derived stem cells from the patient's own bone marrow. This in this one is the patient. This is autologous, so it's the patient's own cells. So they did the administering a couple of different doses of bone marrow cells in these patients, and they tracked to see kind of which doses did better. Did intracavernosal injections, and at 6 months they had improvements in both the erectile hardness scale as well as Doppler flow parameters. And the patients who received the higher doses did better than the patients who received the lower doses. 9 of 12 patients were reported to have sex successfully, again, with PDE5-Is, no safety concerns. This is another one. This is autologous, so it's adipose derived from the own patient's fat, taking the mesenchymal stem cells out in patients who have had ED from radical prostatectomy. 17 men, severe refractory ED. After 6 months of treatment, they had half of them, 8 of 17, recovered erectile function and were able to have sex. And EHS scores improved, but it took some months. It took up to 6 months for that to happen. The patients who were incontinent coming in, the patients who had prostatectomy that led to incontinence did not improve. And that's something that I always talk to my patients about when I'm screening to do procedures on them, is that these patients do not tend to do as well because they have, more severe disease, more severe problems and damage, no safety issues. And then the last one in humans was a very small 8 patients, again, human men who had ED. They were given placental stem cells, which usually these placental cells are actually not stem cells. They are oftentimes like growth factors, but these may have been real cells. I don't know how they verified that, but they did. Almost half of them were able to obtain erections afterwards with using PDE5Is. This next one is just, it's actually a few years old now, but this was a non-systemic review of the animal literature at the time, which basically showed that these mesenchymal stem cells, whether they're from bone marrow or adipose, have been shown to be beneficial in a variety of animal models for ED. And I did not put them all in the slide presentation because you would have been super bored, and so would have I. But again, the last sentence here, which I should have underlined, but it says that these MSC effects they seem to be because of these paracrine effects, these signaling effects, versus those cells actually engrafting into the penile tissue. All right, last but not least is low intensity extracorporeal shockwave therapy. It's kind of a handful, a mouthful, but it's also been called just shockwave therapy or acoustic wave therapy or pressure wave therapy, or the protocol, like I said, that I use is called Gaines wave therapy. But it's all the same thing. The way that this works, and this is super cool, this technology has been around for decades. It's only been studied for ED for about 10 years, and most of the studies are out of Europe. There are about 40 studies total, including 15 or so human studies and the rest animals. But that shows that they send these acoustic waves, these high pressure waves into the tissue, and this could be used in all over the body. They've done cardiac ischemic studies with them. They've done multiple different types of musculoskeletal injury studies. But what it does is it creates micro trauma. So you get this micro trauma, and then the body's like, hey, we got micro trauma, we got to repair it. So you send out this cascade of biological, reactions, including things like increasing VEGF, which VEGF is then going to increase endothelial growth and blood vessel formation. It increases, so you get increased angiogenesis. That was seen in a porcine model with ischemia, with cardiac ischemia. We know that the increased VEGF, again, then you also get the blood vessel, then you also get some homing in of stem cells. So they saw recruitment of endothelial progenitor cells, as well as other cells. Some studies have shown recruitment of other mesenchymal stem cells. So essentially the stem cells flock to the area because they're like, hey, we got to repair this tissue. And they do all the things to do that. This also causes increase in local nitric oxide production. So we see increases in the epithelial nitric oxide synthase, which is going to, again, that's the enzyme that makes nitric oxide. That's kind of the last step. We also see increases in neuronal nitric oxide synthase, VEGF, increased smooth muscle content in the corpus cavernosum as well. So there's a lot of data on there. A lot of just data in ED, but if you're interested in this, which I am, you can look, there's data on everything from treating wounds to neuropathy to cardiac ischemia to, fasciitis. And this is super simple and very elegant, I think. I'm only going to go over a couple of these studies because there's so many of them, but this was a systemic review meta-analysis that was done in 2016 that looked at the data currently using shockwave therapy for ED specifically. So this is 14 studies with humans. There were many more with animals. 800 something patients, and 7 of them were randomized controlled trials. And they measured the IIEF, again, these are both questionnaires, the IIEF and the EHS. And then they found that patients who had mild to moderate ED had a better therapeutic efficacy than patients who had more severe ED, which is true, and I found that to be true in practice. Although I will say that the patients who have more severe ED or they have a lot of comorbidities, a lot of them still will respond. It just takes more treatments. So the treatments, generally, I'm doing about 6 treatments per patient when we first start. So I do them about twice a week for 3 weeks. We do 6 treatments, and that's the starting point, and that works for a lot of people. But people who've had ED for a long time, or they've had severe prostate, disease problems in the past, or they have diabetes or other things, they may need more treatments. And so I have patients who've done 12 treatments or even more, and a lot of them do continue to see benefit with more treatments. All right, in this meta-analysis, this is just kind of going over the different settings, and I think this is not necessarily something you have to know right now, but if you want to do this treatment, of course, this is valuable information. The studies included patients who'd had, ED from radical prostatectomies, from Peyronie's disease, patients who just had sort of regular ED, vasculogenic ED, as well as patients who had some pelvic pain associated with it. And the clinical outcomes, they did see overall increases in the IIEF after treatment. They did see that it took some time. So up to 3 months for some patients, it took 3 months to see results. And patients who had that mild ED, they had more improvement than ones who had more severe ED. And of course, if they paired the low intensity shockwave therapy with PDE5Is, you had even better symptom improvement. I pair my shockwave therapy with PDE5Is, as well as the penis pumps, as well as the Neo40, as well as, let's look at your testosterone, as well as a P shot. I do all of it together, and it all seems to work in harmony, at least for a lot of people. And then this, lastly, again, talking about doing things together, are several studies, a couple of animal, at least one human, in pairing stem cell injections into the penis with shockwave therapy. And with all of my patients now, if I'm doing stem cells or I'm doing PRP injections into the penis, I'm always doing a shockwave therapy, a Gaines wave treatment beforehand. And because I love the idea, these studies have shown it as well, but I love the idea of creating that micro trauma with the shockwave therapy and then going in right afterwards with the growth factors and the stem cells to repair that trauma. And these few studies seem to support that. This is diabetic rats, and they did basically, they did the shockwave therapy, so extra ESWT is extracorporeal shockwave therapy, 3 a week for 4 weeks, or they did stem cell injection, or they did both. So, and they had a sham. And what they found was that the patients, the animal patients, on the far right there where it says ESWT plus MSCT, that's the shockwave therapy plus stem cells. And you can look, and that's looking at their intracavernosal pressure. And the combination of that did significantly better than either of those two therapies by themselves, and significantly better, certainly, than diabetics who didn't have anything. And then the sham was, healthy rats who don't have diabetes. What's their ICP? So it seemed to be really good together. This is another one that's this is the same one. It's talking about mechanism of action, and it seems like that combination of shockwave therapy plus stem cells, you get more angiogenesis, you get more recruitment of even other stem cells, VEGF expression, more nitric oxide activation. And again, it's important to note that these things are decreasing apoptosis of those smooth muscle cells in the corpus cavernosum. So we're keeping those cells healthier. In this one, they saw more autophagy. So this is sort of the way that we get rid of the cells we don't want in a safe way that's non-toxic and that allows us to have sort of a happy cellular area. So we want autophagy, we don't want apoptosis, and that's what these therapies seem to do. Another combination study, basically the same thing. We did, again, shockwave therapy plus adipose-derived stem cells. This is a post-prostatectomy rat model, though, versus the diabetic model. And it showed the same thing as well, that the combination of those two work better and that we can get improvements in a lot of different things when we do those things together. And then finally, in humans, Dr. Elliot Lander, who is out of California, is a urologist who did this study with combining SVF. SVF is stromal vascular fraction. It's just taking stem cells from adipose tissue. So it's basically adipose-derived stem cells combined with shockwave therapy for Peyronie's disease. He's also done one for ED that I don't have in here, but with Peyronie's disease, they took 11 patients. They did a single treatment of the stem cell injection into the penis, and they did either a series of shockwaves between 1 and 6. And I talked to him about this. Most patients were traveling in to see him from out of the state. So most patients just got one shockwave therapy treatment. Some patients who were local got more. That's why why it says 1 to 6. But all patients had subjective improvement in curvature and plaque size, and 7 of 11 had improvements in erectile function. And he saw improvements in various rating scores as well. He has a similar study that looks at that shockwave therapy plus stem cells for ED that also showed, again, that those two are better together. So that's kind of my wrap up here. This on the left, the little device looking thing, that's my device that I use for my shockwave therapy. It is, that one is from Stores. It's the D-Actor 200, I believe, but there are several devices out there that work. Gainswave is the protocol that I use. Nitric Oxide, that's a testosterone in the middle there. And then of course you have your PRP separation and your penis pump, and that's me being really ridiculous. And as one final note here, I'll let you guys read this. And that is the end of my talk. I hope that it was informative, and I'm happy to answer some questions if you have any. Thank you.
Oh, that's great. Thank you, Dr. Killen. You're cracking up. Love it. So we've got a bunch of questions, and I want to be time sensitive so we can get through as many as we can. And then if we miss any, I will send them over to you and get some answers, send them to the larger group.
Okay.
If that's okay. Okay. Question came in. When it comes to PRP, what type of solution are you trying to obtain? And it's more specifically leukocyte rich or poor, and what are the concentration levels?
So in sexual health specifically, that hasn't been looked at very closely. Certainly with musculoskeletal injuries and treating joints and things, there have been so many studies they've been able to dial in, like how many leukocytes do we want? It hasn't really been looked at in sexual health, that as far as I've seen. And I think that we're at a point where we're just beginning to do these studies anyway. There are not very many out there. And right now they're just doing PRP. And I've seen anything, as far as concentration, some of these studies are not using a lot of, the PRP is not that concentrated, but for the most part, with my PRP procedures, I'm looking for the concentration, again, to be about 6 to 9 times whole blood concentration, so that you're getting about 1 million platelets at least in that concentration. And that has been shown, at least with hair and skin, which I also do, to be the optimal concentration. Once you get more concentrated than that, then it actually is like a bell-shaped curve. It actually becomes less effective. And once you get too low, it's less effective. Although, even with low concentrations, at least in hair and skin, again, which is where it's been studied more, it's still effective, even if it's not the perfect combination of platelets. But 6 to 9 is what I like to use. So for instance, if I draw 55 milliliters of blood from a patient, then I'm going to be able to collect about 8 to 10 milliliters of PRP from that blood. So it's pretty concentrated. I don't know about the leukocytes, though. In order to answer that question, we don't know. I usually have some in mind, because I like to get all the platelets that I can, and they're all there together, kind of in a little layer. But we don't know for sure what the best concentration is on that.
Okay, perfect. Thank you. Another question: do you perform PRP injection under ultrasound guidance?
No, I do not. It's just, these are pretty simple injections. You're going into the corpora, and it's not very deep. You can usually, anyone who's done any penis injections, you kind of get used to just where the anatomy is, avoiding the blood vessels and the blood vessels and nerves, of course. But when you do the injection, you can kind of feel the give when I go through the tunica, and I know I'm in the right spot. So I don't use ultrasound. I think it's pretty simple without it, but you could.
Okay, thank you. Another question: are you activating the PRP with calcium chloride, and is using a kit necessary?
I do activate my calcium if I'm just doing PRP, because that's most of the studies that have been done. Again, there aren't a ton, but what has been done, they usually activate it. So the amount that I use, just to keep it simple, I use about 10% of the volume of calcium chloride that I'm using for my PRP. So for instance, if I had 5 mLs of PRP, then I would use 0.5 mLs of calcium chloride, and that's a 10% calcium chloride. Or you could also use calcium gluconate as well. But so it's about 10% of the volume. What you don't want to do, you have to make sure that if you do activate with calcium, that you're going to use it right away, because I'm injecting through, I use a 27 gauge needle to inject. And so the calcium chloride will turn that PRP into a, kind of a sludgy mess. I can't think of the word. Like, it's more viscous, right? After about 10 minutes or so. So if you're going to activate it, like, be ready to inject it right then. Don't activate it and then get called away to a patient or a phone call or, whatever. Because if you come back 30 minutes later, you'll have a tube full of, potentially uninjected, is that a word? PRP that can't be injected through your 27 gauge needle because it's too thick. As far as using a kit, I do tend to use kits. I've used all different kits in the past. I like using kits because I know what I'm going to be getting as far as concentration, because each kit, the makers of it, when they got approval for it by the FDA, they have to show what the platelet concentration is, when you do it by the recommendation, their instructions. So I do use a kit. You don't necessarily have to use a kit, but I think it's probably better, especially if you're going to be doing a lot of these procedures.
Okay, thank you. When do you use PRP versus stem for male or female sexual problems?
That's a good question. And I do some stem cell injections, and what I tell patients, and what I think is the truth, is that we just don't know for sure how much better stem cells, whether they're stem cells from bone marrow or fat or umbilical cells or exosomes, we don't know how much better they are when you just compare them just to PRP. Now, there are more studies and more coming out every day that are showing that these stem cells and other biologics like that are seem to be really effective. But no one, as far as I've seen, no one has compared, doing just PRP alone, injections in the penis, versus like adipose-derived stem cells versus exosomes versus, this versus that. So I can't say for sure, how much better those stem cells are, or if they're better. So I talk to patients about that. Some patients, they just want to do the PRP, and let's start there. And I always do, I really recommend the shockwave therapy, the Gainswave. I think it's really important if you're going to do any of this, that you also do that, because it works. So a lot of times I'll start with that PRP and the shockwave therapy, the testosterone, the nitrates, etc. And then if that's not working, maybe we step up a level and we think about doing some stem cells or some exosomes, but that it increases the cost quite a bit to do those things. So I don't oftentimes jump to that unless they just really want to go straight to it.
Okay, thank you. I know it's 2 after. Maybe one more question, if that's okay.
Yeah, no, it's fine. I'm good for a little bit longer.
Okay.
And then you can also email or something me if you need to.
Perfect. Okay. Do you ever add sodium bicarb to decrease the burn?
In women, I do. If I'm doing the O shot, especially the intravaginal injections, periurethral injections can really sting. And so I will add some bicarb in there with them. I don't find that with men that the injections sting for the most part. Like, once we get into the corpora, as long as I'm in the right spot, it doesn't burn, it doesn't sting. Now, I've had occasional times where I have it, where I injected and maybe I didn't go all the way in, or I'm still kind of in between, the tunica and the skin and, whatever, and that will burn, but it tells me, hey, you're in the wrong spot. So then I got to go in further. But if I'm in the right spot, then it doesn't sting and I haven't needed to add it.
Okay, perfect. Okay, for any other questions that we may have missed, we'll get that from Dr. Killen and send them out. Dr. Killen, thank you so much for your time. This was absolutely wonderful. We really appreciate it.
Thank you, guys.
Thank you.